We will discussing about the second chapter of preclinical Kaplan pharmacology, and now is the second part of the second chapter. So let's dive into it. First of all, we are going to discuss about the dose response curve, also known as the graded or quantitative dose response curves, okay, in which on the x-axis we plot the dose of the drug, and on the y-axis we plot the response or the percentage of the response that we are obtaining from that particular drug. So we plot the dose or log doses versus the response for drugs, and i.e. the drugs are also known as the agonist, and that agonist activate the receptors, and we then can gain informations about the affinity, potency, and efficacy of that agonist. So let's revise about the terms affinity, potency, and efficacy. First of all, the affinity. Affinity is the ability of a drug to bind to a receptor, okay? And the only way the affinity of the two drugs can be compared, that if those two drugs have the parallel slopes or parallel curves, right? So that the affinity of those two drugs can be compared. Potency is defined as the ability of the drug to have a particular response at a particular dosage, okay? That for example, if the drug A at low dosage have a maximum effect and the drug B at higher dosage had the same effect, so drug A would be more potent than drug B. And the rule for the measurement of potency between the two drugs is that those two curves shouldn't be crossing each other, okay? There should be no intersection between those two curves. And efficacy is the maximal response from a drug that we can obtain, and after that no higher dosage can produce further effect. So it's like effectiveness, efficacy. Let's discuss about these two curves, i.e. the AB and XY curves that are representing in the slide. First of all, the difference between A and B, we are interacting these two curves. Do they have the same slope? Yes, they have, because they are interacting with the same receptor. They have the same pharmacological mechanisms, so they have parallel slopes. It means they have identical curves, A and B. So the rule for affinity was that affinity can be compared if the slopes or the curves are parallel. So in this regard, can we compare those affinities? Yes, we can. We can compare the affinity of A and the B. So who has more affinity for the receptor? The rule for the affinity was that the closer to the y-axis, the more the affinity, right? So drug A has more affinity as compared to the drug B because it's closer to the y-axis. What about the potency? Rule for the potency is that the curves shouldn't be crossing each other. So these curves cross each other? No, they don't intersect. So we can measure the potency as well. And the drug A at such low dosage, right? For example, this particular dose can produce a maximum effect. On the other hand, the drug B is producing the same effect at the higher dose. So drug A is the more potent drug, right? And efficacy, both of these drugs A and B or agonist have the same efficacy because they reach the same height. Let's talk about X and Y. They have different receptors. They don't have the same receptors, so their curves are not identical. We are not seeing parallel or identical curves in this second diagram, right? So can we compare the affinity of these two? No, we cannot, because the rule for affinity was that the curves should be parallel or curves should be identical to each other. We cannot measure the affinity, or we cannot compare the affinity of X and Y. What about potency? Yes, we can compare the potency because these two curves are not intersecting, right? And which curve or which drug is more potent? Of course, it's X, because X is closer to the y-axis, and X reaches the maximum like response at a small dose as compared to the Y that reaches the response at a higher dose. So X is more potent than Y. And efficacy, of course, which drug has maximal effect? It's X. and X has higher efficacy as compared to the Y. So talking clinically, that which of these factors, either the affinity, potency or efficacy, is most clinically relevant or important. Among these three, efficacy is clinically most important. We are concerned with the effect of the drug rather than the dose. We are more concerned with the effectiveness of the particular drug rather than the amount of the dose that we are administrating. Talking about the full and partial agonist, what are full agonist and what are partial agonist? Full agonist is a drug that produces a maximal response. They have maximal efficacy, right? They have the higher efficacy, as in this diagram the B is the full agonist. It has the 100% efficacy. Okay. Partial agonists are those drugs that are incapable of eliciting a maximal response. In this particular diagram, A and C are partial agonists. They are not eliciting a maximal response on the dose response curve. They have maybe 50 or 60% response. So, discussing about this graph is that drug B is a full agonist. It has the greater efficacy as compared to the drug A and C that are partial agonist. What about the potencies? Can we compare the potency of A and C? Yes, we can. We can compare the potency of A and C because these two curves are not crossing each other, right? So A is more potent or C is more potent? The A receives a response, particular response at low dosage, and the same response is achieved by C at a higher dosage. So A is more potent than C. And can we compare the potency of B and C? Yes, we can, because these two curves are also not crossing. So B is more potent than C because the response eliciting by the B at lower dosage as compared to the C. So A is more potent than C and B is more potent than C. But we haven't made a comparison yet between A and B. Can we compare the potency of these two drugs as well? Are you sure that, for example, if we continue to add more dose of A, these curves intersect or these 2 points cross each other? As far as the rule of the potency is concerned, that if these two curves cross, we cannot measure the potency of A and B. But there is one thing that we can make sure of. What is that? It means that before intersection, let me make it clear here so you can understand it well, that for example it's 50% of the response, it's 100% of the response, and A is somewhat here and we can draw B somewhat here. Okay, so you can be well clear of that. Up till now, before intersection of these two curves, the potency of A is greater. It means that before this point A is more potent than B, but after intersection B became more potent than A. It means that A is more potent than B at low dosage, okay, before the intersection of these two curves, and B became more potent than A at higher dosage after the intersection of these two curves. We can just make a conclusion that although their potency cannot be compared because of the fact that these two curves are intersecting each other, but in an imagination we can observe that before the intersection the A remains highly potent than B, and after the intersection when A is somewhat here, B is more closer to the y-axis and B is more potent than A. Let's discuss about the duality of the partial agonist. We are talking about the partial agonist, right? So we will start from there, that if a full agonist binds to a receptor, it will have a full response, 100% of the response. Okay, we are discussing about percentage of the response. And if the partial agonist bind, okay, there will be somewhat 50% of the response. In this example, we have been shown that 50% of the response is achieved by a partial agonist. Let's take examples in place of full and partial agonist. Full agonist in this example is epinephrine, and the partial agonist in this example is pindolol. Let's talk about pindolol and epinephrine. Pindolol is a beta blocker and it's a partial agonist right here. That here is the activity of the pindolol and this is the activity alone of the epinephrine. For example, in an experiment, we take a test tube and place the heart inside that test tube and add pindolol, okay? And the heart start to beat slowly. Why slowly? Because pindolol is a partial agonist. It's a partial agonist. It has the capability to elicit like partial response. It cannot elicit the maximal response out of that. Okay. In the second test tube, we add the heart and we add on that heart epinephrine. Epinephrine is a full agonist. It will cause the heart to beat very rapidly because it's a full agonist. It has maximal response capability. And in the third tube we are adding that heart, and now we are adding both the partial agonist pindolol and the full agonist epinephrine. The question is that how will this heart will beat? The answer to this question is that it will beat somewhere between the two. It means that pindolol has a heart beating slowly and epinephrine has a heart beating rapidly, and when we add these two together in one heart, the beating of the heart will be somewhere between the two. Let's talk about this diagram. It means that when we add epinephrine alone, there is 100% of the response, and when we add the partial agonist alone, the pindolol, the effect is 50%. But when we add pindolol to the epinephrine, the slope starts to decrease. It's very important to remember that when we add a partial agonist to a full agonist, the slope starts to decrease. It means that this partial agonist is acting as antagonist to that full agonist. Okay, it means that this partial agonist is acting as antagonist, and more the partial agonist is going to be added, the more is the antagonizing effect. Are you understanding that? That curve starts to decrease after we have added pindolol. Okay, the curve starts to decrease when we add pindolol as if it was the curve of pindolol alone. Okay, pindolol alone has the curve of this, right? But if we add pindolol to epinephrine, the curve also starts to decrease. It means that the curves does not like go towards the touching the x-axis, because partial agonist is still a agonist. It has some capability to have some response, so it will have somewhere between the two. Let's revise it. It means that when we add a full agonist, it will have a full response. When we add partial agonist alone, it will have a partial response. But when we add both the full and the partial agonist, the response will be somewhere between the two. It means that the partial agonist is acting as antagonist to that full agonist. In this condition, pindolol is acting as antagonist to the epinephrine. I hope you understand this. The other terms for regarding this chapter is the antagonism and potentiation. Antagonism means that the drugs that are antagonizing something, okay, they are acting opposite. And there are two types of antagonist. First is the competitive antagonist and the second is the non-competitive antagonist. And you should remember that most of the drugs are competitive antagonist, and some drugs, I will mention their examples, that some are the drugs that are non-competitive antagonist. In the middle of this graph, in the middle of this diagram, there is a control drug. Control drug means that this is the agonist alone that we are using. Okay, middle of the curve is a control, it's the agonist, and on x-axis we have plotted the log dose of that agonist, and on the y-axis we have plotted the percentage of the response. So let's add competitive antagonist. When we start to add the competitive antagonist to that system, the dose response curve shifts to the right. It is identical. The curve is identical and it shifts towards the right. Why we get the same curve? It's very important to understand that when we add competitive antagonist to that agonist system, why we are getting the same curve? It is because how this competitive antagonist is interacting with the receptor. These competitive antagonists interact with very weak ionic bonds with the receptor, and there is like series of transient interactions of binding and unbinding. So agonist has the capability, agonist drug will bind to the receptor when this competitive antagonist is in unbinding state. Are you understanding? That for example, we are adding competitive antagonist to the agonist and these both have the same receptor, right? The competitive antagonist will start to have weak ionic interactions with that receptor and it will undergo a series of binding and unbinding, and in this process of unbinding, the agonist drug, which is the control drug, will bind to that receptor, and when we add more concentration or more quantity of agonist, it will overcome the effect of the competitive antagonist and the curve will only shift towards the right. It means that the potency will be decreased but efficacy will not decrease. It means that only by adding more of the agonist we can have the full response even in the presence of the competitive antagonist. So we will get still the efficacy, same efficacy, but the potency of that system would be reduced. Talking about the non-competitive antagonist, in which these non-competitive antagonists bind to the receptors very strongly. They do not bind to the receptors with weak ionic bonds. They bind with the receptors with strong bonds, okay, and they do not allow the agonist to bind to that receptor when they are in contact with that, so they cannot fully generate the response. Even if we add very large quantities of agonist to that system, in the presence of non-competitive antagonist, we cannot achieve the same response. So it results in decrease in the efficacy of that system. Okay, we cannot achieve the same full effect or same full response from that system. As I have told that most of the drugs are competitive antagonists, but some drugs are non-competitive antagonists. What are those drugs that are non-competitive antagonists? First is the phenoxybenzaimine. It's a beta blocker. You just need to remember their names. Not all of them are mentioned here, but most important them are mentioned here. First, phenoxybenzaimine, it's a alpha blocker, sorry, and it blocks the alpha 1 and alpha 2 receptors both. Second is the heart drug digoxin, it's antiarrhythmic, okay. Third is the allopurinol, it's the gout drug for treatment of the gouty arthritis. Fourth is proton pump inhibitors, IEPPIS. They block the proton pump in the stomach and it's the medicine for the treatment of gastritis. And the fifth is the aspirin that blocks the activity of cyclooxygenase and they inhibit the production of prostaglandins. You just need to remember their names. These are the non-competitive antagonists, okay? We have discussed this pharmacological antagonism. I have told you that these have same receptors. If it is competitive antagonist, it will have the antagonist and the agonist will have the same receptor. Competitive antagonist will act on the same receptor as well as the agonist will act on the same receptor. In the same regard, the non-competitive antagonist will also have the same receptor and agonist will bind to that same receptor. In case of competitive, what I have told you, that in case of competitive, adding more of the agonist can overcome the effect of competitive antagonist and it will reduce the potency. But in case of non-competitive antagonist, adding more drug is not worth it. It results in decrease in the efficacy. Okay, what is potentiation? Potentiation, it's a rare event in pharmacology. Let's discuss in this diagram that GABA. GABA is the gamma aminobutyric acid. It's a chloride channel opener, right? It can open the chloride channel by itself. This is the graph for potentiation. This is the graph for potentiation. For example, we considered GABA as the agonist. It's the drug, it's the control drug. When we add GABA alone, it can open the chloride channels well by itself. But when we add benzodiazepine to that system, it will increase the effect of GABA. It will potentiate the effect or the activity of GABA. And so, what would you expect? Potency will be increased in this case. When we add benzodiazepine, it will potentiate the actions of the GABA and the curve will shift to the left. It means that the potency of that system is being increased. It's like potentiation. We are providing some more power, some more potential to that drug that are already we are using. Okay. There are other two types of antagonism. We have discussed about pharmacological antagonism, competitive and non-competitive. Then it comes the physiological antagonism. What is this? They both have different receptors. It means that the two drugs will have two different receptors, and these two different receptors have two different responses. The most common example for that is the vasoconstrictor and a vasodilator. Vasoconstrictor is the phenylephrine, okay, and the vasodilator is nitroglycerin. Phenylephrine will have its own receptor, which is R1, and nitroglycerin will have its own receptor, R2. Okay, receptor 1 and receptor 2. They both will have different receptors. They will elicitate different responses opposite to each other because these are antagonists to each other. They have opposite responses. What is chemical antagonism? Our last topic for today. It's not an interaction between drug and the receptor, it's interaction between two drugs. Okay, it's a drug-drug interaction and no receptors are involved. And these two drugs are antagonists of each other. One drug is acting opposite to the other drug. Example is the protamine binds to the heparin. When protamine binds to the heparin and they have reverse actions, protamine can reverse the actions of heparin. These both are antagonists to each other. And metal chelators. What are metal chelators? The examples are succinimers, dimercaprol, and deferoxamine. These are metal chelators and they bind to various heavy metals. As the name suggests, that they have the ability to bind to the heavy metals and they can have antagonist effects. Okay, so we have discussed about the graded dose response curves. We have discussed about our concept of partial and full agonist, duality of partial agonist, antagonism and potentiation, and some examples or types of antagonism, i.e. the physiological and the chemical.